Assalamu alaikum. This is the final lecture, inshallah, will be about after coming head and written second twin. First, to talk about after coming head, we have to have a clue about breech presentation. In breech presentation, the line is longitudinal line and the podalic pole present at the pelvic brim. Longitudinal line either cephalic, the head as the pelvic brim, or breech presentation, the podalic pole or the podalic part as the pelvic brim. It is the most common malpresentation. Any presentation a part of cephalic presentation vertex, it's a malpresentation. The most common is breech presentation. The incidence at 28 weeks is 20% and at term is 3 to 4%. So it's associated with prematurity. Types of breech is 3: extended breech or Prague breech is the most common, is the commonest type of breech. The leg extended at the knee and flexed at the hips, with the feet near the face. It's sometimes confused called Frank breech. Image A represent the Frank breech. Flex breech has knee flex and the feet below the breech. The most common called complete breech. The flex breech or complete breech, the knees will be flexed. Footling breech, one or two legs extended at hip and knee, both extended hip and knee, so the feet may be prolapsed down at the birth and has the highest risk of cord prolapse. In a Frank breech, the feet will be extended at the knee and flexed at the hip. In complete breech, this will be flexed in hip and knee. In footling breech, one or two feet will be extended at the knee and at the hip joint. Risk factors: prematurity is the most common cause. Factors preventing spontaneous version: there will be difficulty in spontaneous version, breech with extended legs, twins, oligohydramnios. The ligature will help and allow movement of the fetus in U2 intrauterine. So oligohydramnios will restrict the movement of the fetus. Congenital malformation of the uterus: the available space will be restricted, short cord, or the baby will not be freely mobile. Intrauterine fetal death. Favorable adoption: as hydrocephalus, the big head can be well accommodated in the wide fundus. The hydrocephalus prefers the position of breech. Placenta previa: the lower uterine segment will be occupied by the placenta and contracted pelvis. Undue mobility of the fetus: hydramnios الهيبول hydramnios بيكون في excessive movement and multiparous women with lax abdominal wall. Fetal abnormalities: examine trisomy 13, 18 and 21 اللي هي Tau Edward and Down syndrome. Anencephaly: myotonic dystrophy due to alteration of fetal muscular tone and mobility. This is a risk factor for breech presentation. Breech either will be delivered by cesarean section or vaginal delivery. The complication of after coming head occur mainly at vaginal delivery, so we'll talk about vaginal breech delivery. Vaginal breech delivery either to be assisted vaginal breech or vaginal breech extraction, which will different from each other. Assisted vaginal breech delivery is when the natural process of labor, including maternal effort, cause flexion and descent of the baby. هي الميكانيزم of labor اللي بتحصل للكيفاليك presentation similar ليها بيكون في للبريتش. تمام. And the obstetric maneuvers are all used to freeze the head and limbs. Traction is avoided almost completely, at least until the birth of the umbilicus. Wait and see. Until the delivery of the umbilicus. Even the maneuvers will be used to deliver the head and limbs only. Vaginal breech extraction: when you apply traction on the baby to pull it down, either by fingers on the flexed groin or pulling on the feet. In UK, it's not recommended for vaginal breech except for second train. The worry is that traction can cause the trunk and neck to deflex by Moro reflex. Moro reflex, one of the primitive reflexes, making the baby look upward, called stargazing, which would draw the highest cephalic diameter volume into vertical 14 centimeters and make difficulty in labor. Prognosis of vaginal breech delivery: maternal and fetal. Regarding maternal, labor is usually not prolonged. First stage of labor not prolonged, تمام. But because of increased frequency of operative delivery, including cesarean section, the morbidity is increased. Operative delivery either for subsubvenous or cesarean section included in operative delivery. So the morbidity is increased. The fetal risk in terms of prenatal mortality is considerable in vaginal pre-delivery. The dangers to the baby: intrapartum fetal death, especially if preterm, injury to the brain and skull, to the brain, intracranial hemorrhage by compression and decompression of the unmolded after coming head. Vaginal delivery of cephalic presentation, there is molding to decrease the head circumference and pass through the birth canal. In breech delivery after coming head, there is no molding occur. So result in tear of the tentorium cerebelli and hemorrhage in the subarachnoid space. The risk mainly in preterm babies. Also, fracture of the skull. So there is intracranial hemorrhage and there is fracture of the skull. Birth asphyxia due to cord prolapse and cord compression by the buttocks and the delivered part of the fetus, and then during the fetal delivery will be compressed into the pelvis. Retraction of the placental side after delivery of the trunk will be retraction in the uterine side and the placental side, and there is beginning of placental separation. Premature attempt at aspiration, the fetal head will be in utero and there will be premature attempt for respiration, and there is amniotic fluid and vaginal fluid. There is delay in delivery of the head and prolonged labor regarding especially second stage of labor. Birth injuries, fractures, male femur, humerus and clavicle due to manipulation, and dislocation of the joint, hip joint, mandible and cervical vertebrae and epithelial separation due to manipulation and delivery of the breech delivery. Visceral injuries include the rupture of the liver, kidney, lungs and hemorrhage in the testicle. Make sure during breech delivery no compression or traction at a bony part, not the abdomen, to avoid visceral injuries. Nerve, medullary coning, spinal cord injury, stretching of the cervical and brachii plexus cause Erb's palsy and Klump's palsy. To avoid this intravaginal complication and prenatal mortality, there is an option of external cephalic version. External cephalic version is a process to correct this malpresentation from breech presentation to cephalic presentation externally through the abdomen. The RCOG guidelines advise that women with breech baby should be offered external cephalic version as it lowers the chance of cesarean section and breech vaginal delivery. Success rate is about 65%. The time of version considered from 36 weeks, not earlier, to avoid the chance of reversion. Illustrate the process of external cephalic version. External cephalic version is a process have prerequisites, indication and contraindication, but beyond the scope of this lecture and this level. Delivery of the after coming head. After delivery of the breech, the head will be delivered by many maneuvers. There is an obstetric maneuver to deliver the head in breech delivery. This is the most crucial stage of the delivery. The time between delivery of the umbilicus and delivery of the mouth should exceed 5 to 10 minutes. Method of delivery for after coming heads. First, Burns-Marshall method. The baby is allowed to hang at its own weight. The assistant asked to give thoracic pressure. This may represent after coming head. In a breech delivery, at this stage, the trunk will be delivered and the head will be still in the uterine and in the pelvis. It is called after coming head. This maneuver is Burns-Marshall method. In this method, the baby will be hung against gravity and the assistant will be breastfed appropriately. This is called Burns-Marshall method. Can be delivered by forceps delivery. This represents the forceps delivery of after coming head. There is a third maneuver called malar flexion and shoulder traction, modified Meniscus Moribet technique. Two fingers, middle and index finger, at malar eminence to aid the flexion of the fetal head and shoulder traction to deliver. Is medical management of cervical entrapment may be attempted using nitroglycerin to cause rapid but transient relaxation of the uterus. Nitroglycerin administered by anesthetist can be IV or sublingual spray. If all of this fails, this is called entrapment after coming head. This is rare complication occur in two situations. Either the fetal back is allowed to rotate posteriorly. لازم نعرف انه في البريش ديليفري the back will be up، يعني الباك يكون anteriorly ما يكون posteriorly. The fetal back rotate posteriorly. The chin may be trapped behind the symphysis pubis. هيكون في bone impaction between the chin and the symphysis pubis like the shoulder distortion. Correction required difficult internal maneuver to free the chin and push it laterally. بتبقى oblique بدل يكون anterior، بدل يكون من to anterior مع symphysis pubis يبقى من to lateral. Macrobert's maneuver اللي هي hyperflexion, abduction and external rotation and thoracic pressure may be helped زي ال shoulder distortion. The second case to occur entrapment of after coming head in preterm delivery. The body can slip through the incompletely dilated cervix with the resulting head entrapment. If the cervix cannot be stretched digitally, surgical incisions can be made in cervical ring to dilate the cervix, either digitally or surgically by what is called the Herson's incisions. These incisions, cervical incisions, will be at 2, 6, and 10 o'clock to avoid cervical arteries. This image represents the Herson's cervical incisions. This is at 2 o'clock. The fetus with hydrocephalus may present as breech delivery with an entrapped head. Hydrocephalus بيكون عنده large head circumference, one of the risk factors of breech presentation. If presented, if not discovered antenatally and presented with head entrapment, can be suspected by the appearance of meningeal or spina bifida, may indicate the presence of hydrocephalus, which occur in approximately 1/3 of cases. Decompression of the fetal ventricles or kyphocentesis may be detrimental to the fetus, but is the only way for the delivery to be completed if the fetus is alive and rapid cesarean section is not available. Destructive maneuvers بتكون دايما للdead fetus except for hydrocephalus, regardless of viability, alive or not. Kyphocentesis is an option. Kyphocentesis can be done abdominal by needle aspiration abdominal or vaginally by perforation of the head. Certain is the image. Symphysotomy is the last resort that can increase the available pelvic diameters. It is used in low resource setting without ready access to emergency resection. Can be life-saving. This symphysotomy to free trapped after coming head. Replacing the trunk and performing cesarean section. Emergency section for abdominal rescue may be required. Even during cesarean section can occur head entrapment due to contractile upper uterine segment. Acute colitis and or extension of the uterine incision may require to release the head. This occur intraoperative during cesarean section. Locked twins type. If there is a twins pregnancy, the fetus was breached, there is a risk of locked twins, which is rare. It's rare, occurring around 1 in 817 if the twin one is breached, which is rare due to slow descent of the trunk. This image represents locked twins. The locked twins managed by disimpaction, tried under general anesthesia by grasping the head of the second twin, rotating and push it up, and can deliver the first twin easily. Or sacrification of the first twin, which is usually dead, or by decapitation. The second twin can then delivered, followed by extraction of the head of the first twin. Decapitation, separation of the head from the body, and delivery of the second twin, then followed by the head of the first twin. ده لو كان dead. If the first twin is still alive or all of these fail, means-cesarean section will be life-saving. This is a complication of twins pregnancy also regarding the second twin, called retained second twin. leading twin usually be delivered as for singleton. هو غالبا بيكون كيفلك لأنه الفاجينال delivery for twins pregnancy mandate إنه الفيرست يكون كيفلك preferred يكون الفيرست كيفلك. The leading twin usually delivered as for singleton but with care to ensure adequate monitoring of the second throughout. After delivery of the first baby, the lie of the second twin should be checked and gently stabilized by abdominal palpation. After the delivery of the first twin, the assistant will stabilize the second twin by abdominal palpation يخليه longitudinal to make sure it's a longitudinal lie, whatever breech or cephalic. While a vaginal examination is performed to assess the station of the presenting part. The assistant stabilizes the second twin and the other doctor will do vaginal examination to assess the presenting part and the station. Once the presenting part enters the pelvis and the membrane can be broken, the second twin usually delivers within 30 minutes. If 30 minutes pass, this is considered retained twin. Management depends according to the lie, presentation, and station of the presenting part. A lie لو كان if longitudinal lie or transverse, longitudinal regardless, breech or cephalic. Presentation either cephalic or not, and the station it's engaged or not engaged. If it's cephalic and the presenting part below or at scale spine engaged and low, the instrumental vaginal delivery may be an attempt, but in preterm babies, ventouse should be avoided. The risk of intracranial hemorrhage is much common in preterm. The second twin cephalic but not engaged, should exclude cephalopelvic disproportion. Cephalopelvic disproportion or CPD is disproportion between the pelvis and this twin may be the first. As example, in monochorionic twins, in twin-to-twin transfusion syndrome, there is discrepancy between the birth weight in two twins. The first can be small and delivered, the second will be average weight or sizable, and cephalopelvic disproportion will be considered. The possibility of hydrocephalus of the second twin should be excluded by ultrasonography. If cephalopelvic disproportion and hydrocephalus is excluded, internal version followed by breech extraction is performed under general anesthesia. اتكلمنا قبل عن external cephalic version. There is internal podalic version هنتكلم عنها بعد شوية. After internal podalic version هنعمل breech extraction زي جبال. With the breech presentation, breech extraction may be attempted by an experienced clinician. قبل breech extraction قلنا here all indicate في second twin. It involves grasping of the feet of the fetus and gently pulling them through the vagina aided by maternal effort. In modern obstetric practice, second twin with fetal distress is the only acceptable indication for this procedure. لأنه قبل قلنا هيحصل deflection and the engaging diameter will be meant to vertical, which is unfavorable for vaginal delivery. When the fetus is transverse lie, external cephalic version abdominally into a longitudinal lie, whatever كان cephalic ولا breech, but preferably يكون cephalic. لو البيبي كان transverse lie هنعمل external cephalic version abdominally to longitudinal lie. This can be successful in more than 70%. If external cephalic version failed and assuming the operator is experienced, internal podalic version can be undertaken. What is internal podalic version? Internal podalic version is performed by identifying the fetal foot through intact membranes. The foot is grasped and pulled gently and continuously into the birth canal. The membrane is ruptured as late as possible. Internal podalic version is only accepted indication for second twin also. Then followed by breech extraction. This image represents internal podalic version. One hand internally at the podalic part and the other hand externally at the cephalic part. If vaginal delivery is not possible for second twin, immediate cesarean section category 1 should be performed. Thank you. Any question?